Welcome back to the Deep Dive. Today, we are not just dipping our toes in the water, we are jumping straight into the deep end.
Yeah.
We are tackling a legitimate heavyweight champion in the world of medical literature.
It really doesn't get much more foundational or, let's be honest, intimidating than this one.
Exactly. We are cracking open what many consider the Bible of surgery for students, residents, and, well, lifelong learners. Baily and Love's Short Practice of Surgery.
The 28th edition, specifically.
And to be super precise, we are zooming right in on Part 9, Chapter 59.
Cardiac surgery.
Cardiac surgery. Now, I know some of you might be thinking, oh, great, a dry recitation of suture techniques and, flow rates. But let me just stop you right there.
No, absolutely not. That is not what this is.
That's not what we're doing.
I mean, the chapter itself is dense. It's packed with diagrams, physiology, procedural nuances. It is really easy to get lost in the weeds.
Which is why our mission today is very specific. This deep dive is designed to be your ready reckoner. It's our interpretation. We're going to take these complex surgical concepts and translate them into a roadmap that actually sticks in your brain.
Think of this as the scaffolding. We are not replacing the textbook. You still absolutely need to open Chapter 59 to look at the diagrams of the bypass circuits, the angiograms.
The illustrations of the defects.
All of it. But this conversation, this is the framework that helps you understand what you're looking at when you do open that book.
We want to move you from just memorizing lists to actually understanding the mechanics. So we're going to use metaphors, we're going to use some fictional case studies to make it real.
And we're going to do some check-in questions along the way just to make sure this knowledge is really locked in.
And if you don't get the answer to a check-in question, that's your cue. Just rewind, listen to that segment again. It's that simple.
So we've broken it down into 4 main pillars to make it manageable.
We're calling them the engine, the plumbing, the doors, and the blueprints.
Which basically covers bypass technology, the coronary arteries, the valves, and the congenital defects. If you can grasp these 4 pillars, you've pretty much got the entire specialty in a nutshell.
But before we get into the nuts and bolts, or I guess the valves and grafts, we have to start with the hook. Because the history here is actually wild.
Oh, it is.
Baily and Love makes a point of highlighting just how young this field really is.
Incredibly young. I mean, if you go back just 100 years to the early 1920s, the heart was essentially forbidden territory.
Completely off limits.
Yeah.
A no-go zone.
There was this prevailing belief in the medical community. It was almost a dogma that the heart was the one organ you simply could not touch without killing the patient. If a surgeon tried, they were considered reckless.
And then, as is so often the case in science, someone broke the rules.
Sir Henry Sotar. In 1925, he published his report on the first mitral commissurotomy in the British Medical Journal. He basically proved that the heart could be operated on. He opened a stuck valve, but there was a massive catch.
The huge catch.
You can operate on the heart, sure, but you have to maintain blood flow to the brain. That is the fundamental constraint. You cannot stop the heart to fix it if the brain stops getting oxygen.
Because the brain dies in minutes.
In minutes.
Yeah.
So for decades, surgeons were limited to these crude repairs or just working on the outside of a furiously beating heart. Until 1953.
The Holy Grail moment.
John Gibbon. The invention of cardiopulmonary bypass, or CPB. This is the moment the door was kicked wide open. Before that, you were fighting a losing battle against time and motion. Gibbon gave surgeons the ability to stop the heart,
Open it up.
fix the intricate structures inside, and close it again, all while the patient remained perfectly alive.
It really is the moon landing of surgery.
Yep.
So with that, let's get into our first pillar, the engine room. Let's unpack cardiopulmonary bypass.
Okay, let's do it. To really understand bypass, you have to visualize the mechanic's dilemma. So imagine you're a mechanic and you need to rebuild the engine of a car. I mean, the whole 9 yards, pistons, valves.
Okay, got it. I'm picturing it.
But the car is speeding down the highway at 70 miles per hour, and you cannot stop the car. Because if the car stops, the passengers, in this case, the brain, the kidneys, the liver, they die immediately.
That's a nightmare scenario. Literally impossible.
That is heart surgery without bypass. You cannot perform delicate stitching. We are talking millimetric precision here on a target that is thumping 80 times a minute and is full of high-pressure blood. You need a way to stop the engine but keep the car moving.
You need a tow truck.
You need a tow truck. I love that. The cardiopulmonary bypass machine is the tow truck.
So it's taking over the job of the heart and lungs.
Exactly. It temporarily replaces the function of the heart, which is pumping, and the lungs, which is oxygenating. It takes the blood out of the body, does the work, and puts it right back in.
Baily and Love breaks this down into a specific circuit. So let's trace the journey of a single red blood cell through this tow truck. It starts with something called cannulation.
Cannulation is just the surgical term for plugging the pipes in. We need to drain the blood before it enters the heart. So typically, the surgeon places a large venous cannula, a big tube, into the right atrium or directly into the vena cava.
And is there a pump that sucks the blood out?
You'd think so, but usually no. We just use physics. Gravity. The bypass machine itself sits lower than the patient on the operating table, so it acts as a siphon. The dark, deoxygenated blood just flows out of the body and into the reservoir of the machine.
Okay, so now the heart is empty, the blood is in the machine. What happens to it there?
First, it goes through the oxygenator. This is your artificial lung. In the early days, they used to just bubble oxygen through the blood, which was actually quite harsh and damaging to the red cells.
Right.
Modern oxygenators use these incredibly fine, hollow fiber membranes. The blood flows on one side, oxygen flows on the other, and gas exchange happens across that membrane, just like in your own lungs.
So it's adding oxygen, scrubbing out the carbon dioxide.
Yeah, correct. Then it usually passes through a heat exchanger. This is absolutely critical for a concept we'll get to in a second called myocardial protection. We can use the machine to cool the patient's entire blood volume down or warm it back up.
And finally, that cleaned up, oxygenated blood has to get back to the body.
That is the job of the roller pump. This is the artificial heart. It's a simple, reliable pump that pushes the now bright red oxygenated blood back into the body. And the return cannula is usually placed in the ascending aorta, past the heart.
So mechanically, we have bypassed the heart and lungs. The body's getting everything it needs from the machine. But here's the part that I think confuses a lot of people initially. Just because the heart is empty doesn't mean it stops beating, does it?
That's a great point. No, it doesn't. An empty heart will continue to beat. In fact, it might beat even faster because it has no resistance. And as we said, you cannot sew on a beating heart.
So once the tow truck is towing the car, we need to hit the pause button on the engine itself.
Precisely. We need what's called myocardial protection.
And this brings us to one of the most critical terms in the entire chapter, cardioplegia.
Which literally translates to heart paralysis. Once the bypass is running smoothly, the surgeon places a cross clamp across the aorta. This completely isolates the heart from the rest of the body's circulation. Then we inject this cardioplegia fluid directly into the coronary arteries.
Okay, so what's the secret sauce? What is actually in that fluid that stops the heart cold?
It's potassium. A very, very high concentration of potassium.
Why potassium? I remember from basic physiology that it's all about electrical gradients, but can you walk us through the actual mechanism here?
Sure. It goes right back to cellular physiology. A heart muscle cell contracts based on electrical signals, which are driven by ion gradients, sodium rushing in, potassium rushing out. It's a delicate balance.
Right, the action potential.
Exactly. So what we do is we flood the outside of the heart cells with a huge concentration of potassium. This completely destroys that electrical gradient. You depolarize the cell membrane and you just lock it there. It can't repolarize, it can't fire again.
And critically, what state is the heart muscle locked in?
It's locked in diastole, the relaxed phase. This is absolutely vital. If the heart locked up in a cramp-in systole, it would burn through all its energy reserves in seconds and die. By locking it in diastole, the muscle is flaccid and relaxed.
It's totally limp, ready to be worked on.
Totally limp. And to protect it even further, we usually administer this fluid cold-like 4 to 10 degrees Celsius.
Which is where that heat exchanger we mentioned earlier comes in.
Yes. By cooling the heart itself, we put it into a state of hibernation. Hypothermia dramatically reduces the metabolic rate. If the heart isn't beating and it's cold, it needs almost zero oxygen. It's in suspended animation.
And that buys the surgeon time.
That buys us time, hours potentially, to do this incredibly delicate sewing and repair work without the heart tissue dying from a lack of oxygen.
That is just fascinating. It's controlled suspension of life for a single organ. But surely taking all the blood out of the body and running it through a plastic machine isn't without consequences. The book mentions something called SIRS.
Yes, systemic inflammatory response syndrome. And this is the trade-off. You have to remember, human blood is not meant to touch plastic tubing. It's designed to touch the smooth, slick endothelium of our blood vessels.
So when it hits the bypass circuit,
The immune system just freaks out. It activates the complement system, it releases a storm of cytokines, it triggers a massive body-wide inflammatory cascade.
it thinks the body's under a massive attack.
Essentially, yes. And in severe cases, this leads to leaky capillaries, fluid in the lungs, kidney dysfunction, clotting problems. It's a serious side effect.
So it's a race against the clock.
It really is. It's one of the main reasons surgeons try to keep the pump time, the bypass time, as short as humanly possible. The longer the blood is in that machine, the worse the SIRS reaction can be.
Okay, let's pause there for our first check-in question. This is to make sure you're tracking with the science of the engine room.
All right, let's test the physiology.
Here is the question. We need to stop the heart to operate, and we use a special fluid called cardioplegia. What specific ion in that solution is responsible for actually arresting the heartbeat?
Take a second. Think about that cell membrane, that electrical gradient.
The answer is potassium. High extracellular potassium depolarizes the membrane and stops the heart in diastole.
If you got that, you are ready to move on. If not, just rewind and listen to the section on myocardial protection one more time.
Okay, let's move on to part 2, the plumbing. Coronary artery bypass surgery, or CABG.
Or cabbage, as you'll almost certainly hear it pronounced on the words.
This is all about addressing the most common heart problem in the Western world, ischemic heart disease, basically the clogging of the pipes.
Atherosclerosis. And Baily and Love describes this progression really vividly. It starts as a simple fatty streak, which, scary enough, can be seen even in teenagers or children. Then, over decades, it becomes a hard, fibrous plaque.
And eventually, a complicated lesion that can rupture and cause a thrombosis, a clot, a heart attack. So to understand the surgery, we need a quick anatomy refresher. We're mainly talking about the left main stem and the right coronary artery.
Think of the left main stem as the main trunk of a tree. It's the big supplier. It branches very quickly into the LAD, the left anterior descending, and the circumflex artery.
And the LAD is often called the widowmaker, right?
It is because it supplies the massive front wall of the left ventricle, the main pumping chamber. A blockage there is catastrophic.
And then there's this concept of dominance. The book says most people are right dominant. What does that actually mean?
Yeah, that's a common point of confusion. Heart dominance isn't about which side is bigger or stronger. It's a specific anatomical definition. It's defined by which artery supplies the posterior aspect of the heart, specifically the posterior descending artery.
And in most people.
In about 90% of the population, it's the right coronary artery, so most people are right dominant.
Got it. Okay, let's bring this to life with a fictional case study. Let's meet Robert. Robert is a 60-year-old man. He's diabetic. He's been getting chest pain when he walks upstairs. He went for an angiogram, and they found significant blockages in 3 different vessels: his left main stem, his LAD, and his RCA.
A classic triple vessel disease presentation, a very common scenario.
So the big question is, why surgery? Why not just put stents in? We hear about stents all the time, PCI, angioplasty. It's so much less invasive. Why would you cut Robert open?
And this is a major decision matrix in cardiology and cardiac surgery. According to the text and major trials, CABG surgery remains the gold standard for specific groups of patients. If you have significant left main stem disease, surgery is usually better.
Yeah.
If you have complex triple vessel disease, especially when it involves the proximal LAD, surgery is better.
And what about his diabetes? Does that factor in?
That is the real clincher. For diabetic patients like Robert, the long-term survival is significantly better with bypass surgery than it is with stents. The disease in diabetics tends to be very diffuse. It affects long segments of the arteries. Stents are like spot welding a crack. Bypass is like building a whole new highway around the entire traffic jam.
Great analogy. So Robert gets booked for a CAG. The surgeon needs some spare pipes to build these bypasses. Where do they get them from?
We have a few options, but, and this is a key ready reckoner point for exams, they are not all created equal. The absolute superstar conduit, the gold standard, is the lima, the left internal mammary artery.
And this runs down the inside of the chest wall.
Correct. It's right there, next to the heart. We can carefully dissect it, disconnect the bottom end, and swing it down to sew it onto the LAD downstream of the blockage.
What makes the lima so special?
It's an artery, and it's built differently. It produces nitric oxide. It actively resists atherosclerosis. The results are just incredible. The patency rate, meaning how many are still open and working, is greater than 95% at 10 years.
Wow, over 95%. That's amazing durability.
It's phenomenal. Now, compare that to the other main workhorse, the long saphenous vein, which we harvest from the leg.
The classic leg vein graft.
It's easy to get. There's a lot of it, so you can make multiple graphs. But it's a vein. It is designed for low pressure flow. When you take it and sew it into the high pressure arterial system of the heart, you are subjecting it to pressures it was never built for.
So it gets damaged over time.
It gets damaged. It develops its own atherosclerosis, a process called intimal hyperplasia. At 10 years, the patency of a vein graft drops to about 50–60%.
So let me get this straight. 95% for the artery, maybe 60% for the vein.
Exactly. That's why the Lima to the LAD graft is the single most important part of the entire operation. It's the lifeline.
What about other options? The book mentions the radial artery.
The radial artery from the arm is another good option. It's an artery, so it lasts longer than a vein. But you have to do an Allen's test first.
Remind us what the Allen's test is.
You basically squeeze the wrist to block blood flow from both the radial and ulnar arteries. Then you release the ulnar side to make sure the hand still gets good blood flow just from that one artery. You can't take the radial artery if the ulnar isn't up to the job, or the patient could lose their hand.
A crucial safety check. Now, briefly, the text mentions off-pump surgery, or OPC CAB.
Right. This is doing the bypass without the heart-lung machine. The heart is still beating.
Wait a minute. You just spent 10 minutes telling us we can't sew on a beating heart.
Well, we developed these incredible stabilizing devices. Think of a device like a little octopus that has suction cups on its feet. It can be placed on the surface of the heart and hold just a tiny 2-centimeter area of the heart muscle perfectly still, while the rest of the heart keeps pumping blood to the body around it.
That sounds incredibly difficult.
It is technically much more demanding for the surgeon. The main advantage is you avoid the SIRS reaction and all the other risks of the bypass pump. But the jury is still out on whether the grafts last as long because the sewing is just that much harder to do perfectly on a moving target.
Okay, time for our second checking question. This one is about the plumbing.
Let's do it.
You are the surgeon. You have a choice between using a vein from the leg or the lima, the artery from the chest wall, to bypass a blockage in the most important coronary vessel, the LAD. Which one lasts longer and why?
Think about those 10-year statistics we just mentioned. The difference is huge.
The answer is the lima, left internal mammary artery. It lasts significantly longer, over 95% patency at 10 years, because as an artery, it is naturally resistant to developing atherosclerosis.
Spot on. If you got that, you're doing great.
Let's move to our third pillar, part 3, the doors. Valvular heart disease.
The heart has 4 valves, but functionally for surgery, we're mostly talking about the 2 on the left side, the mitral and the aortic valves. They're on the high pressure side of the circulation, so they take the most stress and wear and tear.
And the problems they develop basically fall into 2 buckets. Stenosis, which means they're stuck shut and don't open properly.
Or regurgitation, meaning they're leaky and don't close properly.
And for the surgeon, the great debate is always repair versus replace.
Yes. And there's a general rule of thumb here. For the mitral valve, we fight tooth and nail to repair it whenever possible.
Why is that? Why not just put a new one in?
Because the mitral valve isn't just a simple flap. It's an integral part of the structure of the left ventricle. It has these strings, the chordae tendineae, that anchor the valve leaflets to the heart muscle, the papillary muscles. They act like struts in a building.
So if you cut it all out,
If you cut all that out, the ventricle can lose some of its structural integrity and its function can decline. So we prefer to use techniques like annuloplasty rings to tighten a leaky valve or resuspend cords to save the native valve.
but for the aortic valve, it's a different story.
For the aortic valve, replacement is usually necessary. It's a much simpler structure, and by the time it fails, it's often severely calcified. It's like a rock. You can't repair a rock. You just have to cut it out and put a new one in.
Okay, so if we are replacing a valve, we have to choose the hardware. This is a huge decision for patients. Mechanical valves versus biological valves.
This is the classic trade-off, and you need to understand it. A mechanical valve is made of pyrolytic carbon and titanium. It is, for all intents and purposes, bomb-proof. It will last a lifetime.
Sounds great, but what's the catch?
The catch is it's a foreign object in the bloodstream, and it is highly thrombogenic. It causes blood clots to form on it. So if you have a mechanical valve, you must take warfarin, a powerful blood thinner, for the rest of your life, every single day.
And that's a big deal. It means regular blood tests, dietary restrictions, a higher risk of bleeding.
It's a major lifestyle commitment. Now, compare that to a biological valve, also called a tissue or bioprosthetic valve. It's usually made from a pig's aortic valve or cow's pericardium.
And so it's natural tissue.
It's natural tissue, the blood flows over it smoothly, it's not thrombogenic, no warfarin needed, but it wears out. It's tissue, after all. After about 10 to 15 years, it will start to degrade and fail, and you will likely need another operation.
Let's use two fictional patients to really hammer this home. Case study 2. We have Sarah and we have Grandpa Joe.
Okay. Sarah is 35 years old. She needs an aortic valve replacement. Maybe she had a congenital problem.
Okay, 35. So she has, let's hope, another 50 years of life ahead of her.
Right. If you give Sarah a tissue valve that lasts 15 years, she will need it replaced when she's 50. Then she'll need it replaced again when she's 65, then maybe again when she's 80. Each reoperation is riskier than the last.
So for Sarah, despite the major annoyance of warfarin, a mechanical valve is usually the better long-term choice. One big operation, and it lasts forever.
Exactly. Now, let's take Grandpa Joe. He's 82 years old, and he has severe calcific aortic stenosis.
Okay, Joe is not looking at another 50 years.
Right. If we give him a tissue valve that lasts 15 years, that valve will almost certainly outlive him. Plus, giving an 82-year-old powerful blood thinners is very risky. They're more prone to falls, bruising, internal bleeding. So for Joe, a biological valve is the clear choice.
That makes perfect sense. Now we have to mention the absolute game changer for people like Grandpa Joe, TAVI.
TAVI, transcatheter aortic valve implantation. I mean, this is science fiction stuff that's become routine.
This is replacing the valve without even opening the chest, right?
Correct. They take a new tissue valve, they squash it down onto a stent, put the whole thing on a catheter, insert it through the femoral artery in the groin.
All the way up to the heart.
All the way up into the heart, and then they expand it inside the old diseased calcified valve.
It just pushes the old valve out of the way.
It literally just crushes the old calcified leaflets against the aortic wall and takes over their function immediately. It's incredible.
And originally, this was just for patients who were too sick for open surgery.
Yes, the highest risk patients. But the technology and the data have gotten so good that its use is expanding rapidly, even to intermediate risk patients. It's becoming the new standard of care for many elderly patients.
Before we leave valves, I just want to touch on the specific pathologies Baily and Love highlights. For mitral stenosis, the book points almost exclusively to one cause.
Rheumatic fever. It's less common in the West now, but globally it's still a massive problem. The inflammation from the strep infection causes the valve leaflets to fuse together, creating that classic fish mouth appearance.
And for aortic stenosis in the elderly.
That's usually just age calcific degeneration. Or, in younger patients, it's often a congenital bicuspid valve they were born with. And the symptoms are the classic SA triad: syncope, which is fainting, angina, which is chest pain, and dyspnoea, which is breathlessness. And a key point: if you have aortic stenosis and you start fainting, that is a massive red flag. The mortality rate shoots up dramatically at that point.
All right, that brings us to check-in question number 3.
Let's see who was listening to the Sarah versus Grandpa Joe debate.
If a patient receives a mechanical heart valve, what medication must they take for the rest of their life?
It's that powerful blood thinner.
The answer is warfarin or other anticoagulants. Without it, the valve will almost certainly clot off, and the patient could have a devastating stroke or die.
The stakes are very high indeed.
Okay, our final pillar, part 4, the blueprints, congenital heart disease.
This is where the anatomy can get really interesting and a little confusing. To understand the defects, you first have to understand that a fetus in the womb does not use its lungs.
All right, they're filled with fluid. They're not breathing air.
Exactly. So in the womb, the circulation is set up in parallel. Blood comes from the placenta, full of oxygen, goes to the right side of the heart, and then it skips the useless lungs to go straight to the body.
How does it skip the lungs?
It does this through 2 special holes, or shunts. The foramen ovale, a hole between the atria and the ductus arteriosus, a vessel connecting the pulmonary artery to the aorta.
Then the baby is born, takes its first breath, and everything changes in an instant.
The lungs expand, the pressure in the lung circuit plummets, and those 2 holes slam shut. The circulation instantly switches from parallel to series. Now it's right side to lungs, lungs to left side to body, in a continuous loop.
But when that switch goes wrong, or the plumbing is built wrong to begin with, we get defects. The book splits these into cyanotic and acyanotic.
Or, as we often think of it, blue babies versus pink babies.
Let's start with the blue babies, cyanotic.
This means deoxygenated, blue blood is bypassing the lungs and going straight out to the body. It's a right-to-left shunt. The most famous example, by far, is tetralogy of Fallot.
Tetralogy means 4. What are the 4 defects?
Okay, here they are. 1, a large VSD, which is a hole between the ventricles. 2, pulmonary stenosis, a blockage of the pipe going to the lungs. 3, An overriding aorta, meaning the main exit pipe is sitting over that hole, 4. And right ventricular hypertrophy, which is a thickened right-sided muscle from pumping against that blockage.
There are some classic anchors here for students to remember this one.
There are. On a chest x-ray, the heart often has a boot-shaped appearance. And clinically, these kids do something very characteristic called squatting.
Why do they squat? What does that do?
It's amazing they do it instinctively. When they exert themselves and start to feel faint or turn more blue, they squat down. This kinks the big arteries in their legs, which dramatically increases the resistance and pressure in their body.
And that back pressure.
That back pressure forces more blood to go the hard way through the tight pulmonary valve to the lungs to get oxygenated. They literally pink up right in front of you. It's a survival mechanism.
That's incredible. The other big cyanotic one is transposition of the great vessels, or TGV.
This is a complete plumbing disaster. The pipes are crossed, the aorta comes off the right ventricle, and the pulmonary artery comes off the left ventricle.
So you have two separate closed loops. The blue blood keeps cycling to the body, and the red blood keeps cycling to the lungs. They never meet.
It is totally incompatible with life unless there is some other hole, an ASD or a VSD or a PDA, that allows the blue and red blood to mix, even just a little bit. On X-ray, this has a classic egg on its side appearance.
Egg on its side. Got it. Now, briefly, the acyanotic defects, the pink babies.
This is usually a left to right shunt. Oxygenated red blood goes to the lungs, comes back to the left side of the heart, and then some of it leaks back through a hole to the right side and goes through the lungs again.
So it's inefficient. It floods the lungs.
It floods the lungs and causes heart failure. The most common ones are ASD and VSD, but I want to talk about coarctation of the aorta.
Okay, what is that?
Coarctation is a narrowing a pinch point, like a kink in the descending aorta, usually just after the arteries to the head and arms have branched off.
So it's like stepping on a garden hose.
That's the perfect analogy. The heart is pumping hard against that pinch point. So upstream of the pinch in the arms and the head, you get very high blood pressure. But downstream in the legs, you get very low blood pressure.
And this leads to a classic clinical sign that you can find on examination.
Yes. Radiofemoral delay. You feel the pulse in the wrist at the radius, and then you feel the pulse in the groin at the femoral artery. Normally, they should peak at the same time. Here, the femoral pulse is weak and noticeably delayed.
And the body, being clever, tries to bypass the pinch.
It does. It massively expands the arteries that run between the ribs, the intercostal arteries, to create a collateral network that bridges the gap. These arteries get so big and pulsate so hard that they actually eat away at the bone on the underside of the ribs. On a chest x-ray, you can see rib notching.
That is a great visual. Ribs literally being eroded by pulsating arteries. Okay, time for our final check-in question.
Let's test those physical exam skills.
You are examining a child. They have high blood pressure in their arms, but you can barely feel the pulses in their legs. What congenital defect should you immediately suspect?
Think about that garden hose.
The answer is coarctation of the aorta.
And don't forget to get that chest x-ray to look for the rib notching.
Wow. We have covered a massive amount of ground here. We went from the impossibility of heart surgery to the tow truck bypass machine.
We talked about plumbing the arteries with the incredible Lima graft.
We debated mechanical versus biological valves with Sarah and Grandpa Joe.
And we decoded the blueprints of congenital hearts, from blue babies to pink babies.
So if you're using this as a revision tool, remember these anchors. Potassium stops the heart. Lima lasts longer than veins. Mechanical needs warfarin. Tetralogy of Fallot is a boot-shaped heart. Transposition is an egg on its side. And coarctation causes rib notching.
Those are the hooks. You hang the rest of the detailed knowledge on those simple hooks.
But here is a final provocative thought to leave you with. Baily in Love, Chapter 59, traces this amazing history, from do not touch the heart to cut the whole chest open. But towards the end of the chapter, with things like TAVI and advanced stents, we're clearly seeing the rise of the interventional approach, right?
We're moving from big zippers on the chest to tiny punctures in the groin.
So where does the future lie? Will the cardiac surgeon of 2050 put down the scalpel entirely and just use catheters and wires? Or will the complexity of cases like our friend Robert's always require the traditional open approach?
You know, the line between interventional cardiologist and cardiac surgeon is blurring every single year. The future is almost certainly going to be hybrid. combining the best of both worlds in one room at the same time.
A fascinating space to watch. To all the learners out there, now is the time. Go grab the book. Look at figure 59.22 for the tetralogy of Fallet. Look at the angiograms. Let the images cement everything you've heard today.
Knowledge is only potential power. True understanding is the real power.
Thanks for diving deep with us. We'll see you on the next one.
Goodbye.